Okay.
I did this question on there too. I don't know if it's right.
So the first piece of advice is always read what the question's asking you first. So the question here is asking us mLs per hour. So you always want to pick out the things that you need. So in here, you need the total number of mLs and the total number of hours.
Yes.
So your total mLs here is 1,000 and the number of hours is 8. So if you just simply take your total number of mLs and divide it by
The 8
your
hours.
hours, that's going to give you a rate of about 125. It should have gave you.
Yes, that's what I got.
Yes.
Yeah.
Now, I like keep it simple, stupid math, but if you want to do it the hard way, there you go.
No, I was trying to do it this way, and it's like I get it, and then I'll get to a next problem, and then I'll get it wrong. So I don't know.
Okay, my brain doesn't have the capacity to do this. It moves way
Mine don't
too
either. I've been
fast.
trying to learn it with Miss Z, but it's just not coming across.
Okay, Ms. Z likes the long math.
Yes.
Okay,
But I'm trying to
Here's
learn that way
another
too.
one.
That way I have different options.
yeah. Here's another one, okay? How many mLs per hour is a nurse administer to fluids? Now, how are you going to set this one up?
I did the, well, see, I did this the long way, the 500 mLs times the 30 minute, divided by the 30 minutes.
Okay, so you can't divide it by 30 minutes because your 30 minutes is in minutes. And in order for this
Right.
problem to come out right, your minutes has to be in an hourly frame.
In the
Because your
60 minutes,
answer is
yeah.
going to be what?
I got 1,000 mLs though. I don't know if that's great.
That's right. But what you would do is just take the 30 for those of you that don't know.
Would we divide it by 60?
Yes, and that should give you 0.5.
5, right, okay.
So it's 0.5 of an hour.
Mhm.
So that puts your time into an hourly frame now, so that way you can actually do the math.
Mhm.
All right, so 1,000 was correct. Anybody not get this or not understand? Okay, here's the next one. This is going to be the same way, right? You're just going to take the 30 divided by 60. It's going to give you 0.5. When you divide 50 by 0.5, it's going to give you 100. Which
So take
actually,
the 0.5 and then divide it by the 50?
50 divided by 0.5
50 divided by 0.5, okay.
should give you 100.
Yes.
Okay.
Yep, this is the one that I got wrong, yeah.
Which actually, I mean, if you look at the problem, I mean, I encourage you to do the math so you don't get them wrong. But
Yes.
if you're putting something in 50 mLs in 30 minutes, and I'm usually putting it in an hour, then I'm going to have to double the rate to get it in an hour.
Right, so anytime it's 30 minutes, you would divide it by 60.
By 50, because 30 minutes, you're dividing it by 0.5, not by 50.
Yes, I mean, like the 30 minutes, you would, to get it for the hour, you take the 30 divided by 60 anytime it's 30 minutes. Unless they're
Correct.
asking
The
for minutes
reason
an
why
hour.
you want to do it that way is because when you take 30 and divide it by 60, that gives you your time in hours.
Yes.
Okay.
So if they're not asking
What
for
if
hours,
it was
just leave it.
68 minutes?
Mm-hmm.
What if it was 68 minutes? What would you do?
68 minutes. Would you leave it the same?
No, you have to convert that 68 minutes into an hourly rate. So no matter what your minutes is, you're going to divide it by 60, right?
Okay.
Right.
That's going to tell you that portion of an hour, because you can't do this problem with your time in minutes. Your time has to convert to the hourly time.
Okay.
So that's why I'm saying that to you. So no matter what your minutes are over here, you have to make them into hours. So regardless of what that says, if your answer is asking you for mLs per hour, you're going to take whatever those minutes are and divide them by 60. And that's going to tell you what you are in hours.
Okay.
Okay.
Yeah, that's what I was getting wrong. Okay.
Again, you could try to do it this way. I just don't have the tolerance for it myself.
Yeah, I was trying that way
That's-
and I got
That's
it all
too
wrong.
much.
Too
It
much
is.
work when you
That's
only got
too
a minute and a half to do the answer, okay?
Mhm.
You only got a minute and a half on each question.
Yeah.
All right.
Yeah, I
let's-
like your way better, Miss Sue. That's how I learned in the beginning, like when I first went to LB in school, just like this. So this is easier for me your way.
Okay. So now let's look at this one. What's the question asking us?
How many drips a minute?
How many drops per minute? So I know that I need
Mhm.
three things. My total volume,
Mhm.
which is what?
75 mLs,
Okay. My time in minutes, which is what?
60 minutes,
Okay. And my drop
60.
factor.
15
So it's 75 divided by 60 times
times
50.
15. Yeah.
$18.75.
And you can't give 18.75 drops. So now what are you going to give?
So would it be 19?
Yes,
We would
ma'am.
round it up to 19. Okay.
I think this was a problem when they didn't round it, or they did round it. Oh, okay. 1875 equals 19. Mhm.
On drops, we always round to the nearest whole number.
Okay.
Okay, again, ask what's the question asking me?
Drips per minute.
So as soon as I see drops per minute, I know I
Drops per
need
minute.
three things:
Mm-hmm.
the volume,
Mhm.
the time in minutes, and the drop factor.
Yes. Okay.
What'd you get?
Okay, I got it. 40.
I gotta, maybe I do, wait a
Rock
minute.
stars.
Yeah.
Okay.
You got it.
Mm-hmm.
Here's another one. What's the question asking?
The drops per minute.
60 times 60. Oh, okay. Got it.
And what'd you get?
40.
Another 40, yeah.
40.
Perfect. Here's another one.
This is the for drops in the orders.
Ten, 20.
And what'd you get?
21.
Mm-hmm.
You're rock stars. You got it.
All right. All right.
Yeah, because
That
I was
sheet,
confused
Miss
with
Sue,
that
that-
first one.
Miss Sue, thank you. That sheet that you gave me for the math, oh my
Uh-huh.
goodness, it helped me so much. Thank
Good.
you.
Good. All right. What's this one asking?
How many mLs an hour?
So now how are you going to do this one? So you need an hourly rate. So the first thing you have to do is put your drops into an hourly rate. And if there's 18 drops per minute, how many would there be in an hour? So it'd be 18 times 60 because there's 60 minutes in an hour, right?
Right.
Mhm.
Mm-hmm.
And then you divide that by your drop factor.
Wait, I can't see it. I don't know what happened to my screen.
Oh, okay.
Wait, Miss, I can't see you. I see myself more than I see you. I don't know what happened.
I'm not sure. I didn't change anything. So it's
I
something
didn't
on your
know.
end. Go to
Okay.
view on your, in the corner of your, if you have to, you might have to drag your Zoom screen open and then go up where it says view.
Okay, yes, thank you. Thank you.
No problem. So we're doing mLs per hour. So we need our time and an hourly rate, and we need our drops per ml. So our time and an hourly rate is going to be 18 times 60 because there's 18 drops in a minute. So we need to know how many drops in 60 minutes because that equals 1 hour.
Okay,
Mhm.
So you should have got something like 1,054 or something.
yes.
And then
I
you
got
divide that
1,080.
by 20, it should have gave you like 54 drops.
Yes,
whatever it
54,
was.
yeah.
I don't know.
Mhm.
I'm not doing the math. I'm just talking. So what'd you get?
54.
54, yep. So that's how you do that one. I was struggling with that one too.
So this is just in reverse.
Yeah.
Just in reverse. So you times first and then divide
Correct.
instead of dividing first and then multiplication. Okay. Yeah, okay.
I never read anything in the problem until I read what the question's asking me, because if you read the problem first, then you get confused. Just read what the question's asking you and pull that out. And we're going to go to some actual problems in a second so you can see what I'm talking about.
Okay.
All right, here's another one. What's it asking?
The mLs an hour.
mLs per hour.
So the first thing you have to
So
do is convert that
8
drop
times
rate into an
60.
hourly rate.
660. Okay.
Got 40 mLs an hour.
40.
Yes,
I got 48.
48. Yeah,
I
missed
got
something.
48.
Okay, well, let's try the 48 because that actually sounds more realistic, just because we're taking 48 times 60, then we're dividing by 60. So we should end up back with the number
Divided
we
by
started
60.
with.
Yes, yep.
Okay,
I
good
missed
job.
this.
Always double check. Always make sure you clear your calculator. Always double check your calculation.
Okay.
Okay, while you guys do this one, did it change my screen?
No.
Okay,
Now it
good.
did.
All right, well, I'm going to go into Saunders anyway, because I want to pull up some questions that have actual problems attached to them so that you'll be able to decipher what you should be pulling out.
Okay.
You guys got the numbers for that?
I got 150.
Yes. I got 150.
Rock stars. Okay, you should be able to see new questions now. So let's start with the first one.
How many mcgs of the Joxin to administer each dose? Mm-mm.
What'd you guys get?
Wait a second.
I gotta run to the ladies' room. real quick.
28.8.
Okay, good.
Mm-mm.
All right, so
Okay,
what
how
you
do you
should
do
have
that?
done here is you should have taken the 8 and multiplied that times 7.2. That gives you your
Mhm.
total daily dose. And
Right.
then you had to divide that by 2.
Oh, okay, that's what I did.
Okay. Nope, missed that.
Yep, me too.
Missed that one.
Okay, there's your rationale.
Okay.
Can you guys see the image on my screen?
Mm-hmm.
Yes.
You can see the atropine label?
No.
I don't see a label. We see the question.
Here's
Maybe
the
if you
label.
click view bigger, we can see it. There we go.
Oh, okay.
So what do you have here?
0.4 milligrams per ml.
So that is your supply on hand. So write that down because I'm going to take this down.
Okay.
All right, now do the math. I got to run to the bathroom real quick.
Okay.
Come in.
Did
I got
anybody?
1.5 ml.
That's what I was about to ask. That's what I got. Anybody else get 1.5?
1.5.
Okay.
Then we're good.
Deborah, what sheet did
Yes.
she give you? I'm sorry, my camera not working because I'm at work. What sheet did she give
I
you?
am too, girl, and I'm in the med room. I'm closed
my
up in the
camera,
med room.
there's no camera on this daggone computer that I'm on, so. But what is it
Okay.
the sheet that she that was attached to the syllabus?
No. After class Monday,
Uh-huh.
Wednesday, I'm sorry. I went to her office for a one-on-one session and she gave me a sheet to work
okay.
on. It was
Okay.
really good. If you want me to make a copy for you and bring it to you Monday, I will.
Monday we not.
Oh no, I won't see you Monday.
we
My
won't
bad.
see you until Wednesday. Yeah.
That's right.
I'll
Well, you
ask
know
her
what?
if she
I'm
can
at
email
work.
it.
You at work. You got a fax machine? I can fax it to you.
Yeah, I do. Let me find the number.
Okay.
Okay.
Okay, how we do?
Good.
You did good.
What do we get?
We all got 1.5 ml.
All right. That means somebody's right. All right, good job, rock stars. Anybody needs to see that rationale?
Can you just go over it really quick?
Sure.
Thank you.
So we have an order for 0.6 IM, okay? And what we have on hand is what?
0.4 ml.
0.4.
Per 1 ml. So doctor's order is for 0.6. Can you see the screen?
Yes.
We have 0.4 on hand per 1 ml. Not too good at writing on this thing. Okay, whatever
Like a
mLs
drunk
are there,
person
you're gonna
writing that.
multiply it times. If it just says per ml, then it's 1.
Mhm.
All right, so 0.6 divided by 0.4 times 1. And that gave us 1.5.
Miss Sue, what about the 20 ml on the top of the label?
So that 20 mLs represents what?
The total
whole
amount in the
bottle.
vial. The whole vial,
Right,
yeah.
so why is it in there? Because when you go to the hospital, right, they're not gonna send you up a dose of just 1 dose in a vial, right? Because they ain't got time for that.
Right.
There's 600 patients in that hospital. So they're gonna send you a 20 ml bottle so you can take 10 or 20 doses out of it, because this way they don't have to keep sending stuff up or running back and forth. So that's all that represents is actually there's 5 or maybe more than that. If it's 0.4 times 5, let's see what that gives us.
And 5, right? 5 doses.
Yeah, 0.4 times 5 equals 2. So there's actually, I think, 50 doses in here.
50,
Yeah, there's
okay.
50 doses of
Right.
this medication in here.
I'm talking about mLs.
So that would give me like 5 days worth.
Mm-hmm.
Mhm.
So that's all that represents. And that's why I tell you to read what the problem asks you first, because then you know what to take out of it. It's not fluff, because if you were to get this on the floor, this is how it's really going to come.
Okay.
So it's not fluff to try to confuse you. They put it there because that's the way you're going to see it when you get on the floor. Okay. The
Thank
primary
you.
healthcare provider prescribes erythromycin suspension 800 milligrams by mouth. After reconstitution, how many mLs should the nurse pour into the medicine cup? Now, whenever you're doing reconstitution, it's whatever you have left on hand, because that's your supply. So we already know our order is 800 milligrams, right? That's
Yes.
going on the top.
Can we see the wording?
In 1 second,
Okay.
we're going to put our 800 up here first, because that's what we have on hand. I mean, that's what our order is.
Mhm.
Let's get rid of this other stuff. And then we'll put our concentration there once we determine what it is. All right, now let's go look at the figure. Okay, so what we have is erythromycin, 200 milligrams of erythromycin activity per 5 ml reconstituted. So this is saying when it's mixed, when we mix it up, what we're going to end up with is 200 milligrams per 5 ml.
Okay.
So that's our dose on hand.
Mm-hmm.
Uh-oh, what'd I do? I'm trying to, oh,
20?
somehow I lost my
Yeah.
screenshot. I'm trying to find it back. I think I might have closed Saunders by accident. Let me open it back up. All right, so what'd you guys get?
20 ml.
20 mLs, yeah.
Okay, so you had 800 over 200 per 5 ml.
Yes.
Mm-hmm.
Since I closed the problem, I'm going to do the math, which it should be right if all of you got it. Okay, 800 divided by 200 times 5, and I got 20. Perfect. All right, let's see if we can get back to Evolve now.
Ms. Loesch,
Yes.
can I just give Deborah a fax number so she can fax me something real quick?
Oh, yeah, I don't care.
Deborah is 973
973
497
497
4753.
4753. Okay,
Thank you so
I'll
much.
fax it right over to you.
That's fine.
you're
I'm right.
welcome.
I'm in the infirmary. It's nothing else coming through. It's fine. Thanks.
Okay, I'll
All right.
fax it right over.
Thanks.
And I have to go do 2 finger sticks anyway. I'll be back.
Okay, who could see the question?
The prescription of 1,000
Yes.
millo.
Mhm.
We can see it.
Where are we reading from, nurse?
Um,
The nurse prepares to set.
yes,
That's where I want
the
you to
flow
read
rate
from.
and how many drops per minute.
So, because that's going to tell you how to set the problem up. So as
Mhm.
soon as we see drops per minute, we think 3 things, right?
Yep. Total mLs, total volume, 1,000 mLs. Mm. Is it 21 drops per minute?
20.8, so 21.
21.
Good job. If you look in the bottom there, it's broken down for you. All right, any particular questions that were on any of the quizzes?
Mm. Yes, let me go get the paper.
I probably know which ones you want anyway. Let me stop my share and go in there. I think it's week 5 where you guys had the issues. Okay, let's look at these ones here. Any of these ones that you guys had a problem with? The first one was reconstitution. We could try that one if you want. Again, it's whatever you have left as your final concentration, that's your supply on hand. So then all you have to do is take your order and put it over that.
That's 1 divided by the 10. Minus 1. See.
And then on these, you're rounding to the nearest tenth.
Yeah, 1 ml.
I got 0.1.
Yeah, I did too. Yeah, but then, oh, because round to the nearest 10th, you would leave it the same, right? Because it's lower. Okay.
Yeah, I got 0.1. That would
Yes,
be
I
the
did.
nearest
Yep,
10th
0.1.
right there. Okay, how about the next one?
Can't see the whole problem. It's kind of.
Number 2.
For some, let me see. Some reason I can't see the problem.
Okay, look at your view screen on your
Oh,
Zoom.
okay. I'm good now. Thank you.
Mhm.
0.5 ml.
No.
Nope. Okay.
So I got 30 on this.
30. Oh, I missed the step. Times 60. Yes, 30. Yep, I forgot the hours.
Okay, so for this problem, for anybody who doesn't know how to do it, let's throw it up on the board.
Thank you.
Okay, so it's asking us, the order is, I got to look at the order again because I forgot already.
1 milligram and 2 grams.
1 milligram per minute is the order. And on hand, we have 2 grams in 1,000 mLs, and it's asking us for mLs per hour, okay? So the first thing we're going to do is we have to convert this minutes to hours. So since we have 1 milligram per minute, we're going to take that multiplied times 60. And that means we're going to give 60 milligrams in an hour. That way we converted our time from minutes to hour, okay? That's your first step. Now, the second step is, this is what we have on hand. So this is going on top. On the bottom, we have 2 grams per 1,000 mLs. The art of this. All right, so this is going to convert, right? To
Right.
2,000.
To 2,000.
So it'd be 60 divided by 2,000 times your 1,000. You understand why we did all those steps?
Yes.
Okay. So then you should end up with 30. Okay, which is the correct problem for that answer, the correct answer for that problem. All right, the next one is a straight drop factor. So you guys can do that one if you want. Again, it's drops per minute, so you have to do the conversion.
Your screen is still on your writing screen. The screen is not up. Thank you.
So if we're converting drops to minutes, okay, our total volume is 1,000 mLs. That's already there for us. We have to convert that 10 hours into minutes by,
By 60?
multiplying it by 60. So that should give us 600 minutes. So now
Yes.
our problem should be set up 1,000 mLs divided by 60 minutes. I mean, by 600 minutes
Times
times
the
the drop
20.
factor, which
Times
is
the
20.
20.
Yep.
I missed
33.
something.
Okay, what'd you miss?
Well, because I came in late, so
That's fine. Just tell me what you missed.
what you said from the beginning of this problem,
Okay, so it's drops per minute whenever,
right?
and what I'm teaching you guys is always read the question first, okay? Because otherwise you might be taking stuff out of the problem you don't need. So it's asking us for drops per minute. In order to solve this, we need three things: the total volume, which is always going to be in mLs, our time, which has to be in minutes because our problem's going to end up in minutes, and our drop factor. So our total volume here is 1,000 mLs, and that goes on top.
Okay.
Our total volume is 10 hours, but we can't take our time in hours. It has to be in minutes. So how do we get that to minutes?
You said multiply it times 60.
Right, and that's going to give us 600 minutes, right?
Yes.
So now we have 1,000 mLs divided by 600 minutes, and then we're going to multiply that answer times 20 because that's our drop factor. So for these questions, it's always total volume over your total time in minutes times your drop factor. And it's always rounded to a whole number because we can't give partial drops.
You did. What did you do? How did you get 600? Oh, you did it times 10, right?
Because
Time.
you have 10 hours.
Okay. All right.
There's
Okay.
60 minutes in each hour. So
Got
we're
it.
going to take 10 times 60 to give us the total number of minutes for a 10-hour period.
I understand. Okay. I just didn't. I needed to see a visual. That's all.
Okay, here's a
But
visual.
I understand the math.
Here's a visual.
Thank you.
Just that I can't write that well on this board, so I'm trying.
I appreciate that.
All right, so here's the visual. All right, we have 1,000 mLs. That's our total volume. And we're giving it over 10 hours. And our drop factor is 20. Okay, so for this problem, anytime you're asked for drops per minute, you need your total volume, and that's always going to be in mLs, over your time in minutes, times your drop factor.
Okay.
So we already have our total volume because that's 1,000 mLs because it's always in mLs. So we have 1,000. Now our time is in hours. So we have to convert that to minutes before we do the math. So in order to make 10 hours into minutes, we're going to multiply it times 60 because each hour represents 60 minutes. And that'll give us 600 minutes.
Got it.
So we can cross this out and we're going to divide by 600 and then multiply times our drop factor, which is 20. So you do the 1,000 divided by 600 first and then multiply that times 20. And what'd you get?
I'm doing it now. I'm sorry. I was writing it. $33.
That's right.
33.
That's right. If you got 33, you got the right answer.
Okay. Naima, turn that light on. You doing number 5?
Yeah, this is the one I struggle with on there.
Okay.
Yeah.
Okay.
So we have 1,250 units per hour. Okay, so the first thing we have to do, right? If there's 1,250 units in an hour and there's 60 minutes in an hour, we have to take the 1,250 and multiply that times 6.
960.
Okay,
Okay.
that's what the step I didn't do.
I like doing this conversion at the beginning of the problem.
Mm-hmm.
Now that should have gave you 75,000.
Yes.
Mhm.
And you gotta divide that by 50,000.
Yeah, because you're 1.5.
I gotta make sure I'm doing this right.
Oh, they want the answer in minutes.
Okay, 25.
I got 90.
I got 90 also.
Hold on a second. I gotta make sure I'm doing this right. So this one's a little tricky.
$90.
I got 90.
Okay, I think the issue with this one is the first thing we have to do on this one, there's gonna be a few more steps in this one. Okay, the answer here should be 25,
Okay.
and I'm gonna show you how to get to it, okay? So let's go
Okay.
backwards a little bit and let's just start from scratch with this. So the first thing we're gonna do is go ahead and take the 1,250 units and divide it by 50,000 and multiply that time 1,000. That's gonna give you 25. Okay, and the reason why
Wait,
we're
say
doing
that again?
is- you see how you have 1,250 units on the top, right? On the
Uh-huh.
bottom, you have 50,000 per 1,000. So we're gonna take
Uh-huh.
the 1,250, we're doing a simple order over have on hand, right?
Yeah.
Okay.
So if we do that, order over what we have on hand, we would take the 1,250 over the 50,000, right? Divided by that and multiply the whole thing times 1,000. And that's gonna give you 25 mLs.
Yeah, straight. Damn.
Okay, but that's not really your answer because we're given 25 mLs per hour. So now we have to take our total volume which is 25. And you're gonna divide that by 60 because it's 60 minutes, which is an hour.
Mm-hmm.
And then you're multiplying the whole thing times 60. So you're still gonna end up with 25,
With 25.
but you really have to do that step in order to get it to the minute rate. Because once you do what you have on hand over what you need over what you have on hand, that's really giving you mLs per hour. So in order to convert that down to the minutes now, you have to take your total volume, convert that 1 hour into minutes, and multiply the whole thing times your drop factor, really to take it all the way down to the correct answer. Do you guys understand why I did that?
No.
No, I'm sorry. I'm lost. I'm so sorry.
Because what I
That
did,
one.
Miss
You said
It
1250
came out to the right answer when you only did half of the math. But the problem is, if these numbers weren't the way they are, you wouldn't get 25 both times.
Well, I did it the way you did in the beginning. I took the 75, divided it by the 50,000, got 1.5, times that by 1,000, got 1,500 and divided by 60 and got the 25.
Okay, so that's another way you could do it. It still brings it out to the minutes.
Yes.
But I was trying to stay in tune with what we were previously doing.
Okay. Okay.
Okay,
So this is what we
so-
were previously doing, so let me show you. Let's go to the board. So what we have on hand is $12.50 per hour. I mean, that's what our order is, $12.50 per hour, okay?
Mhm.
12.50 units per hour.
Mhm.
Now, if they were just asking us for the dose, we would just take that over the 50,000 units. And then multiply it by the 1,000. Right? Because that's what it gave us in the problem. But when you do that, that's giving you your mLs per hour, really. So when you calculate this out, you should have gotten 25. Do the math. Is that what you got, 25 there?
Yeah.
Yes.
So really, see, because we didn't convert our time, that's just 25 mLs that we're gonna give. We still have to take that down into minutes, drops per minute, remember?
Mm.
So if we take our 25 mLs, because that's our total volume now, and our time is still 60 minutes, because 1 hour equals 60 minutes, right?
Mhm.
Mm-hmm.
So we still have our total volume over our total time, and then our drop factor is 60. This works out to be 25 still, because the drop factor is 60. But what if the drop factor was 20? It wouldn't come out to 25. It would come out to something different.
Mm.
So you see why I want you to break it all the way down. You have to break it all the way down. I don't think you'll get any of these on an exam. All right.
Thank God.
Not my favorite types of questions, but it's something that you might have to do in the future. All right, let's go to another one. Let me try another quiz. All right, let's look at the first one. Now, again, read what it's asking you.
Miss Sue, your other screen is still up.
Okay.
Which number?
Number one, we'll do first.
Okay.
So what's it asking you?
How many mLs an hour will I know set the IV infusion pump?
Okay, so we have 200 mLs and it's going over a half hour. Okay, those are the only two numbers you need. Our total volume and the time that it's going in hours. So for this, we have 200 mLs and it's going over half an hour, which is equivalent to what?
30
In
minutes.
hours.
30 minutes.
No, that's in minutes. We need it in hours.
Oh, yeah,
Oh,
it's an hour.
0.5.
0.5. Good. So it's
Oh, okay.
200 divided by 0.5. And it should be 400.
400, yeah.
Mhm.
Wait, what? Oh, y'all did the math. Wait, say that again, please.
Okay, so this is asking us mLs per hour. So you need your total volume in mLs, which is 200, and your total time in hours. And we have a half hour. So how would you write that?
200 mLs
Divided by,
divided by, I would have said 30 minutes, but you
but you
said
can't
no.
divide it by 30 minutes because your time has to be in hours.
Okay, so
So what is 1/2 of an hour equal to that you could put there as a number?
0.5.
0.5.
And if you don't know that, take the 1 and divide it by 2. That'll give you your fraction, your decimal, I mean.
Okay, I got what you're saying. Okay,
Or take
I got
30 and divide it by 60.
got it. Okay.
Okay, so what you should have gotten here is 400. You take the 200, you divide it by the 0.5, that should give you 400. Okay, let's look at the next one. Infusion of 480 mLs was ordered to infuse in 1 hour and 15 minutes. After 15 minutes, the remaining volume is 160. Calculate the new flow rate to complete the infusion on time. So we already went for 15 minutes, but it was supposed to go for an hour and 15 minutes. All right. So what we have left, our time is now what?
An hour.
All right, we're 60 minutes. Okay.
320.
What is our total volume here?
320.
160.
160 is left.
Okay. So we have 160 left and we have 1 hour.
Right. So it's 160. 60
160 divided by
times 10.
27.
27.
What'd you get?
27.
27, yeah.
Oh, what did I do wrong? I think I put 1 less 0. Okay, that's what I got, 27. Okay, let's look at the next one. I think this is the last one we can do unless you guys have another one you want me to do before I go off. Because I'm going into L to R next.
Okay.
Is there any other question besides this one that I'm going to do with you that you would prefer me to do?
Which question are you doing? 3 or 4?
Number 3.
Okay.
Is it 27?
That's not what I got.
I got 81.
Okay.
We started with calculating forward using 15 fusion time.
Okay, so our bag went for 2 hours out of the 3.5. All right, so that should leave us with 1.5 hours. Anybody have something different?
Oh, I didn't even do that.
Oh, I mixed that up. I took the time at 11 to 11:30. That's why I messed up. I see.
So that should be 90 minutes, in my opinion, 1.5 hours.
Okay, that's what I started with. I just wasn't sure.
So our total volume is 325 because that's what's left in the bag.
Mhm.
So if we take our total volume, which is 325, and I calculated the 90 minutes right, then we multiply that times 15, I got 54 drops.
He said it again, because I left out the time. That's where I went wrong.
Okay, so our bag started at 3.5 hours, right? And
Yes.
it went from 9 to 11, which is 2 hours. So
Yes.
3.5 divided by 2 leaves me 1.5 hours, right?
Yes.
Right.
My calculation of 1.5 hours is 60 plus 30.
Yes.
So that's 90 minutes, right?
90.
Mhm.
And then we have 325 mLs in the bag. So that's our total volume is 325.
Yes.
Our time is 90 minutes. So it's 325
90.
divided by 90. And
Times
our
the
drop factor was 15.
15.
Okay.
So I got 54.
Yes.
Yes.
Okay.
Yep. 54. Okay. Yeah. I keep leaving out the time. That's my problem
Okay.
for most of these. Yeah.
And you just have to make sure your time is in minutes.
Yes.
Okay. All right, guys, I'm moving on to Eldar.
Mhm.
All right, everyone. Miss Sue, I gotta go because I gotta get back on the floor.
Okay.
Thank you, ladies, so much.
I'll be doing that. If you're looking for OB math, that is going to have to come because I got to run through those scenarios myself and figure them out before I present them to you. I haven't done OB math probably ever. I'm going to get it for y'all. I have to learn it first to teach it to you. All right, let's get into Taylor's. So I know I went over 13 and most of 14 with my class. Some of you guys that are on here, let's see if I can figure out where I was on 14 and try to go through 14, 15, maybe some of 16. You guys know that these videos are all available on YouTube, right?
No, I didn't know that.
Yes.
All these chapters are broken down chapter by chapter on YouTube.
What's the webpage or the page name?
You should have the links. I thought I sent them out to you guys.
Let me
It's
see.
under Miss Loesch's name.
Yes.
And
Just
go on
under her
YouTube,
first
just
name.
put her name and all the videos will come up.
Okay, because some of us are on the day program.
Yeah, but I thought I sent it to the day program also, but I'm gonna send it again.
Okay, thank you.
Thank you so much.
So if you don't have it, why don't you do this? Send me an email. So this way, as soon as we're done, I'll try to get those links out to you.
Thank you.
Because I don't have like you guys' like separate email list because of the way the classes are divided up this time. It's
Mhm.
weird. usually everybody's in one class, but now because of the COVID and us being divided up in classrooms, you got like 3 different sections for your day class. All right, where's my stuff? Trying to find the PowerPoints, guys, because I have some that are embellished. I want to make sure I use those ones.
Is your math ones on YouTube as well?
The one
Or-
for today will be on there. There are some previous math ones on there.
Oh,
The
perfect.
one we did
Thanks.
today will probably be a little bit better because
Good, because I feel like I missed them, most of it.
okay, that didn't open up. quite
Miss Sue,
right.
will this video be available right away on the YouTube?
It won't be available right away because I have to convert it first.
Okay.
And there's 2 others, I think, in front of you that have to be converted. So it'll depend on how long it takes them to convert. And actually, I have my granddaughter's birthday party today, so I probably won't be getting anything converted or done right away
Okay.
until I get, and I don't even know like what time I'm going to get back from there or whatever. I have a bunch of companies, so if I can work on it, it's probably not going to be till tomorrow.
Okay, that's fine. Thank you.
Okay, so I'm just going to kind of recapitulate this a little bit, and then I'll try to pick up from where I left off at. Oh, this don't show me the doggone notes. Let me.
What chapter are we going to start from?
We're going to start with 14. I was
Okay.
going through that in class with y'all. I already went over 13. So we're going to start with 14, 15, and I'll try to get to some of 16, 17, and 18. But I really behoove you to watch the videos on YouTube if you don't get to them today. So make sure you send me that link because I can send you out the link right away for the chapters that are already recorded. Just today's recording won't be up there, but all the other recordings are already up there for 13, 14, 15, 16, 17, and 18.
Okay.
All right, so we were talking about assessment, okay? Initial assessment, generally there's some kind of hospital policy in place for that. You're gonna usually do it within the first 24 hours. Okay, so the patient is admitted and we do this initial assessment. We wanna get the baseline data on the patient. Focus assessment, this is for either a problem we're trying to identify or one that we've already identified. And we're going in, we're focusing in on that particular problem. We're asking about signs and symptoms, when they started, anything different, any remedies they might have taken, how they previously may have treated the problem if they had it before. This is kind of used like in a doctor's office or when we just can focus in on one thing. Emergency assessment, this is going to be used for life-threatening issues. So anytime your patient comes into the ER or their 911, they have some sort of life-threatening issue, it could be on the floor, you're going to do this emergency assessment. So this would involve things like a choking patient, someone who was stabbed or a gunshot, someone who's not responsive, or it could be a crisis, someone who's affecting the safety and livelihood of others. Time-lapsed. So this is going to be a focus that we do over time. It could be like a post-op, like every 4 hours, we're going to check this patient's vital signs and compare them against their previous findings. It could be a patient going home on a home care visit. So every 3 weeks, we're going to follow up with them. Maybe they had a cardiac issue, they were in the rehab, and now they're home. And so every 3 weeks or every 2 weeks or every week, we're going to go in and check on that patient. And we're comparing previous findings to the ones that we have now. And then patient-centered assessment. This is where we look at the health, the well-being, the social environment. It's a holistic, what we call a holistic sort of assessment. All right, with patient-centered, we use the PCAM tool, and we're looking at all those different components of the patient. And you can look at more information on that on page 343 on the PCAM. So again, for the initial assessment, generally we're doing that within 24 hours. We're establishing a database, identifying problems, and starting that plan of care. And we're going to use our data that we've collected on the patient's different health status and what's going on. For focused, some of it might be done during the initial assessment or as routine ongoing data collection. We're gathering about a specific problem to identify a new or overlooked problem. The nurse will collect the data about that specific problem. We might ask the patient what their symptoms are. When did they start? Is there anything different today that prompted you to seek care? Anything better, anything worse? Emergency, whenever a physiological or psychological crisis occurs. This is to help identify life-threatening problems. It's performed by the nurse to gather data about those problems. And examples would be, the patient's choking while they're eating. They got stabbed, they got shot, they were found unresponsive. All right, time lapse performed to compare the current data to data gathered earlier. All right, so we create that baseline and then we're comparing. When might we do this? Blood transfusions. Someone's in ICU. Someone's post-op. Someone's on home care. So we're checking and we're comparing to previous findings over a time period. Establishing priorities, okay? Think about the data we need. What is not a priority? So it's the same as when you're doing that SPAR report. When you call the physician or you're looking at the patient, we're not worried about something that happened 10 years ago. What happened in the last couple of days? What's happened immediately prior? What prompted this? What's going on? What's going to help me identify and correct the issues I need to correct now? And then I can go back and look at the other stuff later. Don't waste time if you've already given information in a report or gotten it from the patient to keep repeating it, because the patient's going to get a little annoyed with you. All right, they're going to think that you don't know what you're doing, that you're just repeating yourself. All right, and that they've already given you the data that you need to make the decisions. Okay, if something needs to be clarified or validated, then you would do it. And depending on what kind of nurse you are, where you're nursing at, what is going to be a priority for you. In other words, if I'm working on a cardiac unit, I'm going to be looking at things that are correlated with that. But if I'm on a nutritional unit or a respiratory unit, I'm going to be looking at things that are correlated with that. We do nursing. Doctor does doctor. Okay. The doctor looks at the pathological condition. We focus on how the patient responds to that condition. So what are the things that we're looking at? So psychosocial issues, physiological issues, okay, dizziness. My stomach's upset because I took that medication. It's causing me to have orthostatic hypotension. Those are the things where my focus is in. What is their response to that actual problem? How are they responding to it? How is it working? So medical and nursing are different.
Hey, excuse me. I'm sorry. Is the PowerPoint that you're sharing matching with the topics being discussed? I can't see if it's changing or if it's just the same one.
Oh, you can't see it changing?
No, I mean, I don't know if it's me or if it's
Can the rest of you see it changing? I should be on a slide that says objective data versus subjective.
No,
I'm still an initial comprehensive assessment.
yeah, me.
It's not changing.
Yeah, they're not changing.
How about now?
Okay,
Yes.
great. Thanks.
No problem. All right, so objective and subjective data. So objective is anything that we can observe, we can measure, we can see, hear, or feel. Not the person experiencing it, us. We as the observer can feel this, see it, hear it. If the person that's experiencing it is the only one that can perceive it or feel it, then it's subjective. So things for us that are objective are X-ray results, an elevated temperature, moisture on the skin that we can physically see. We see the patient vomiting. Subjective, pain experience, even if they rate it. Dizziness, anxiousness, those kind of things. Shortness of breath, okay? You can only hear about it. You can't physically see it. Who can give us data? The patient, families, and other caregivers, the patient's record, other healthcare professionals, technology, nursing, and other healthcare literature. Okay, so we're going to use that diagnostic testing, the labs, the consult reports from family, if they're HIPAA and they're there and they know information and we can't get it from the patient. But the best way to validate your biases and stuff is with another nurse. Now, if you're trying to validate information from a patient, you can ask them. And if it doesn't sound right or it doesn't correlate with how they're acting, then you might want to validate that information further. And then your diagnostic testing, your labs, your consults, and talking to other healthcare professionals and collaborating with them. You're looking at your monitors, okay? Your technology. How are those monitors reading? What are those tests saying? What are those results saying? Also, literature, evidence-based practice. You don't know about the disease, you have an obligation to look it up. You don't know about the medication, you have an obligation to look it up and see, where do we stand right now? How are we treating this? And your hospital, your facility might have their own policies also for what you're doing with that patient. So when you're collecting that data, it has to be purposeful. It has to be prioritized, complete, systematic, accurate, factual, and relevant. So purposeful means you know what type of assessment you need and you gather the data that applies to that assessment. Prioritize means you get the most important information first and only really the information that you need. The data should be complete. So when you're asking the patient information, you want to be an investigative reporter, get all the details. Okay, you don't just say, oh, have you lost weight lately? Yes. Okay, patient lost weight. Now, if I go back and read that report, what does that tell me? Hello? I'm not talking to anybody, or you're on mute.
Oh, it doesn't tell you anything because you don't know how much the patient weighed and then how much they lost.
Right. So I need to know, one, were they trying to lose weight? Two, did they do any changes in their diet or their exercise habits? Three, have they really recently been diagnosed with anything that might cause them to lose weight? So all those things you got to take into consideration, and that's got to be part of your report. In other words, you know how when your 5-year-old sometimes draws you a picture and they bring it home? Yeah. And you look at the picture and you think something about that picture, right? And you make the dumbass move of telling your kid what's on the picture. And that's not at all what's on the picture, right?
Right.
Yeah.
So they'll be like, no, mommy, no, daddy, that's not what I drew.
Mhm.
This is what I drew. Okay, this is what happens when you come behind that dumbass nurse that does the charting. You go and you read that picture and you're confused after you read it, right? You're like, what the hell? You want that picture to be clear. That person that's reading your notes should know what that picture says to them. They should understand that documentation when they read it. They should know what you did for that patient, why you did that for that patient, and what the result was or the expected result of you doing that for that patient. Because I'm coming in, I may not get report from you, and I might be doing things for that patient. Now I can go back and read your note and I have a clear picture. Also, 20 years from now, when you're being sued and you got to go to court, you still have that clear picture. Because how many times have you documented on something and went back even 10 minutes later to read what you wrote and you're like, what the hell did I write here? Because you're in a hurry and you scribble it, right? You don't do that ever?
Yeah.
Sometimes.
I do it all the time. Like, my handwriting is atrocious. I probably should have been a doctor. But what I say is when I write it, I can't always remember it. So I have to even myself be conscious of when I'm writing notes to make sure that they're not so much thorough, because I usually capture that portion just because I'm a little anal, but the legitimacy or the being able to read it, all right, being able to read it and interpret it might be another story. I might not be able to interpret what I wrote 5 minutes ago. So I have to make sure I write it clear so that I can read it. Your skill, okay? Your skill determines what you're going to write and what you're going to see with this patient. If you're a lousy person at doing assessment, then your assessment skills are going to be lousy on that patient. So it's something you have to work on, something you have to practice. All right? You have to know what the patient's response is. What is their ability to carry out the care and the instructions that you give them? How will the environment and its safety affect that? For one, do they have availability to the resources that you're giving them? Do they have the capable abilities to perform that equipment functioning? Do they have the capabilities? So let's say your patient is 400 pounds and you send him home with an abdominal wound. Okay, and it's right smack in the middle of the abdominal area by the umbilicus. Let's say she just had a baby, because that's when we're going to have that big C-section wound across the belly, right? Is she going to be able to manage that wound on her own? What do you think?
No.
Why?
Because she run a risk for dehiscence with it splitting open.
So it's not
And you
because
said-
of her risk
said she's
factor, but
400
she's
pounds?
got all this fat around her belly. Is she even going to be able to see the wound?
No.
Man, if I'm obese, can I reach different parts of my body like other people can?
No.
So now I'm either going to have to rely on a mirror or somebody else to help me. And, you know, a lot of other components can go into that. So these are kind of things that you have to think about when you're setting your patient up for care. All right, other things, the phases of the nursing interview. So the preparatory phase, okay? In this, we're getting our stuff together. We're reading the chart. We're reviewing about the patient. You want to know these. You want to know these steps. You'll probably be tested on them. So, you know, the preparatory phase, we're getting those interview skills ready. We're conducting the interview. We're comfortable. We're relaxed. We're setting up the environment. All right. In the introductory phase, we're setting the tone for the interview. We're going to start the interview by telling the person who we are, and we're going to let them know why we're doing the interview. We're also going to clarify the roles of the patient and the nurse. And then in that working phase, we're gathering the information to form that database. So we're looking for the things that we can't see that the patient is going to tell us about, those subjective things like pain, anxiety. And then in the termination phase, okay, any successful interview is ended carefully. And when do we start preparing for termination phase?
In the beginning?
Yeah, as soon as we meet them, right?
Yeah.
As soon as we start, we're preparing for that, okay? And then after the interview, we'll restate anything that we need to, clarify anything that we need to, wrap it up, and then let the patient know when you'll be back. So, for a successful interview, you want to focus on the patient. Okay, listen to what the patient's saying, because what is a habit that we all have of doing now? We're preparing our response while the person's talking, right?
Oh, yes.
So we're not really listening to what they're saying, because if I'm preparing my response, I can't be listening to what you're saying. And then ask about the main problem first. All right, give them questions and comments in an appropriate manner. Avoid any comments or questions that might impede the communication. Okay, like acting like you're not listening, your stance, standing with your arms crossed, or looking like you're not approachable. And then you can use silence and touch appropriately. So we're using open-ended questions if we want the patient to verbalize freely. If we need a specific response, we can use occasionally a closed-ended question. We're validating. Okay, we're validating what is heard. We're clarifying any overt misconceptions. We're reflective. Okay, so when we don't understand something, we encourage the patient to elaborate on it and make sure we understand it. And then sequencing. So put these events in chronological order, and then obtain more patient information if needed. Questions on that?
I'm good. No, good.
So why do we do the assessment? All right, we need to look at the patient's overall health status, identify any problems, and establish a database. So we're using 4 methods: inspection, all right, to look at things in the body systematically. Palpation, touching, to assess the temperature, the turgor, the texture, the moisture. Percussion, striking against to produce sounds. Okay, you should know what those sounds mean. What do they mean? Where would we hear Renaissance at? Resonance, where would we hear that at? Come on, you guys are already PNs. You should know this stuff. Resonance, where would we hear it? That's air. That's indicative of air. Okay, so we're going to hear that over the lungs.
Yeah.
If somebody has asthma or emphysema, we might hear hyperrenaissance. How about a dull sound? Where would we hear that?
Bow.
Over an organ or over consolidated tissue. So we might hear that like if we were percussing over the bladder or something like that, or we might hear it if we were doing the lung fields and the patient had pneumonia or some sort of lung disease. And then auscultation, okay, listening with that stethoscope to sounds produced in the body. Okay, you don't just automatically acquire this skill. You really have to practice this, and you have to tune into the different sounds and tune other sounds out. In addition, you want to make sure you're using the right part of the stethoscope. Now, some stethoscopes, the newer ones, have just one component. They don't have a bell and a diaphragm component on it, but it goes by pressure. So you have to know what kind of stethoscope you have. Okay, other stethoscopes have a bell and a diaphragm, and typically we use the bell for those high-pitched sounds, like vowel sounds. You can hear those real nice with the bell, and the diaphragm for those lower pitched sounds. Then organizing that data. So how are we going to organize it? We want to make sure we don't omit anything that's important. We want to make sure we include anything that's relevant and exclude things that are not, or that are wrong or incorrect. We need to establish rapport, okay? If we don't, then we're not going to be able to get much out of the patient. And then we have to record the data appropriately, not what we observed, but what we actually documented as taking. And then we have to upload the information into the database appropriately. If we don't do those things, then we're going to have problems with our data, and then the findings can be inaccurate and may not correlate with what's actually going on with the patient. If there's a discrepancy between what the patient's saying and what you see, or a lack of objectivity, then we have to verify that data. All right, so we're confirming it. And one reason why we confirm it is so that we make sure there's no errors, no bias, or no misinterpretation. The best person to confirm it with is another nurse. All right, so whenever there's any discrepancy or conflict, it's your job to investigate further. It's your job to support, confirm, or negate the suspicion. Inferences. We use what we call language of cues and inferences to describe an early analysis of data. So subjective and objective data is a cue that something may be wrong, and then we make a judgment from that cue called an inference. So let's say I walk in and I see my patient having shortness of breath, and I see that their legs and feet are all edematous. I might make a judgment call that they're going into congestive heart failure, or that they already have it and it's getting worse. All right, and that's what it really is. I look at the cues and I make an inference or a judgment from those cues. Okay, based on, a lot of it is based on clinical experience, your knowledge, things you've seen in the past. You really can't do this if you've only seen the issue one time. That can make you mess up, right? You only seen something happen one time, and automatically when something happens, you're like, oh, I saw that happen to a patient before. This is what's going on. But you can't just make assumptions like that. You have to fully investigate, get all the clues together, make sure you have all the information together, and then make your inference. Anytime there's a change in the patient's health status, you need to report it immediately. Okay, put it in the database, record it on ink, summarize the objective and subjective in a comprehensive manner. Make sure you're writing appropriately with good grammar, good standard medical abbreviations. You're not talking like you talk when you're in the club, okay? Make sure you're professional. And whenever possible, use the patient's words. You can put them in quote marks. Provide privacy, confidentiality, and professionalism. A lot of nurses have a problem with this when they go in to take care of patients that are on ventilators. All right, there's 2 or 3 nurses in the room. They're all checking equipment, checking this, checking that. And while they're in there, none of them are touching the patient. None of them are engaging with the patient. They're talking about what they did with the club last night, who they bumped, who they're going to bump. And the patient can hear all of this because he's on a ventilator. He's not dead. So how would that make the patient feel if you and 2 other nurses come in the room and they're talking about everything, but they're not talking to you? They're not engaging to you. They're not paying attention to you. Their focus is on everything else but you. Phases of assessment set the stage for the diagnosis. So we do the data collection, we verify it, we report it. We do this clinical reasoning, analyzing judgments, drawing conclusions, and now we're going to make our nursing diagnosis. And that nursing diagnosis is going to be based on what? What's that nursing diagnosis going to be based on? Come on, nurses. If you don't talk about it, if you don't engage, you're not going to learn it.
Yeah. The assessment.
The nursing process.
What's this process?
Wait, what did you ask us? I'm sorry. Susan.
What is that nursing diagnosis based on? It's really based on that person's actual or potential problem, right?
Yes.
In
Yes, I'm
response
talking about
to
problem.
that medical issue. So when you're doing things like, let's say they're getting IV fluids and they have fluid volume overload. They have that fluid volume overload because certain parts of the body aren't maintaining homeostasis and maybe they got too much fluid. So that's a response to the treatment of that disease, right?
Yes.
And that's what you're treating as the nurse. That's what you're dealing with. How can I correct this fluid volume overload? What are nursing interventions that I can do to help this patient in fluid volume overload? The doctor's going to give you the furosemide. They're going to give you the medical stuff. But as the nurse, what can you independently do to correct this or to make it better for the patient?
Check their INOs. Checking their weight.
So I'm just like in general, yes, very good.
Mhm.
Those are the kind of things that you're going to do as the nurse. And that's what's going to be in your care plan. And those are the kind of things that you're going to teach your patients to do for themselves when you're not around. All that has to be married together. It all has to be going in one direction. Because if I'm teaching you and showing you how to do one thing and somebody else is showing you something else, it's going to go in two different directions. And we're not going to be able to resolve the issues or bring that patient back to that previous level of functioning, which is our ultimate goal here.
Right.
All right, which of the following assessments would be performed on a patient to gather data about a previously diagnosed liver cancer?
Focus assessment.
B.
Yeah, focused, okay? So we're focusing in, all right, about a condition already diagnosed. Initial is going to be within what usually?
24 hours.
When they get admitted.
All right, within 24 hours of admission or whatever that policy is. What about the emergency one? When are we going to do that?
When there's an emergency.
Life-threatening emergency.
Okay, stabbings, life-threatening, okay. What about time lapse?
Like a post-op or.
Over a few hours.
Okay, good. Is the following statement true or false? The nursing assessment duplicates a medical assessment by focusing on the patient's response to the health problem.
No.
False.
False.
Okay. We focus on the nursing aspect, the patient's response, actual or potential response, okay, to the health problem. The following statement true or false? A patient rates his pain as 7 on a pain rating scale. This is considered objective data.
False.
False.
Why is it false?
It's subjective.
Because the patient telling you the weight of the pen, we cannot see it.
Yeah.
Thank you. We cannot see it. We cannot measure it. Good.
Sure.
The following statement true or false? Most healthcare institutions establish a minimum data set that specifies information that must be collected from every patient and uses a structured assessment form to organize or cluster the data. What is a minimum data set? You use one every day. So like when you go into the emergency room, you have a specific form, a specific set criteria they want you to collect from every patient that comes to the door, right? When you're
Yes.
in a nursing home, they'll say to you, if the patient has this, this, or this, every 4 hours or every 8 hours or every 3 days, you have to collect this data, right?
Yes.
specific amount of data that you have to collect.
Right.
So that's really what a minimum data set is. It's a criteria that's listed by your institution or wherever you're working at. And there's certain stuff that they want you to collect based on why you're seeing that patient.
Is it vital signs, temperature, weight?
It could be vital signs, temperature, but it also could be some sort of documentation as well that's inclusive. But it would be the minimum amount of information that they would expect you to collect at each encounter based on this structured assessment form. So this is true.
Okay.
In which of the following phases of the nursing interview does the nurse gather all the information needed to form the subjective database?
In the introduction?
Working phase.
Hmm.
The patient database is obtained in the working phase. In the prep phase, the nurse prepares the patient and environment of the interview. The introduction sets the tone for the remainder of the interview, and the termination is the conclusion of the interview.
Got it.
Questions on that? Let's go to diagnosing. If not, all right, so diagnosis is the second step of the nursing process. We've already collected and recorded the information, and now we're going to start analyzing it, looking for cues, trying to draw inferences, and trying to put this together. So we are going to identify how a group or community responds to the actual or potential problem. So what is diagnosis? Why are we making these nursing diagnoses? Come on, nurses. You're going to be tested on this big time. I'm just going to let you know, they're going to hit you hard on the nursing process. You better be ready. So why do we do diagnosis?
So, I mean, we do diagnosis to figure out what we're treating for our care plan.
To identify how a person, a group, or community responds to actual or potential health problems. Okay?
Yes.
Why do we do diagnosis?
To identify
how a person, group,
Or
or
a group.
community
or a community
responds to actual or potential health and life processes.
Okay, so we identify that actual problem or that risk factor, and then we look at what contributes to that. What is the etiology? What is the cause, right?
Yes.
Because if we can fix that cause, we could probably nip this in the bud. If we can't fix the cause, then we can identify strengths, resources, ways that we can help this patient to cope with what's going on with them. So now we're creating a list of suspected problems.
Mm-hmm.
We're ruling out similar problems and diagnoses. We're naming actual and potential diagnoses and clarifying the things that contribute to them. We're determining any risk factors. We're identifying the resources, the strengths, and the areas for health promotion.
Miss Suzanne,
Yes.
did you switch over to chapter 15 already? Because it's only showing chapter 14.
This thing is stupid. Yes, and I thought it reshared, but I guess it's not. How about now?
Yes.
Okay, so concerns, all right? We have to be able to recognize any safety or infection transmission risk. Those have to be identified immediately because we don't want to put somebody in a room with somebody else who might make them sicker. We have to identify how the person is going to respond as a human being. How are the symptoms, the signs, the treatment, how's it going to impact or affect them? How will it affect their ability to function independently and their quality of life? We have to anticipate that complications can occur and what steps are we able to take those to prevent those complications. And then we have to initiate any urgent interventions, okay? You don't wait. If something needs to be treated immediately, you're going to treat it immediately or get help for the patient right away. So in 1950s, the term nursing diagnosis first came out in literature. It came out as a 4-step plan, okay? And then it evolved from that point. In 1953, nursing diagnosis was included to help develop the care plan. In 1966, the accurate nursing diagnosis information comes out, and now we start to seek strategies. We start to look at evidence-based practice and actually evaluate how it affects our nursing care. Then in 1972, the New York Nurses Practice Act comes out. That helps us to identify nursing diagnoses as a legal domain. In 1973, the ANA now includes diagnosis as part of nurses' function. And then in 1973, again, the first national conference for NANDA, which is the classification of those nursing diagnoses, was identified. NANDA was out there to help us to identify and standardize and classify the health problems that we treat as a nurse. In 1980, the ANA puts out their social policy statement. Okay, the diagnosis and treatment of human response to actual or potential problems is what we should be doing. And then in the 90s, they start having these NANDO conferences to try to improve the process. So now NANDA has an international conference every 2 years. Nurses deal with specific problems and diagnoses and ill-defined problems. It's now accepted and an essential step in the nursing process. It's not confused as much with the medical diagnosis, but we're working on getting it more and more accepted. So, you know, being able to analyze, assess, and make a nursing diagnosis. So now in 2015, the standard now reads, the registered nurse analyzes assessment data to determine actual or potential diagnoses, problems, or issues. So that's their new social policy statement for us. So we have different types of diagnoses. There's a nursing diagnosis. This talks about how the patient has these problems that nurses can treat independently. For one, dehydration. How can we treat that independently?
Give them fluids.
Okay, if there's no contraindication, we can encourage fluids and try to get them to drink it, right?
Yes.
With the medical diagnosis, that identifies the problem for which the physician deals with directly. It identifies the actual disease. And you can't put a medical diagnosis in your nursing care plan, so don't try it. Okay, if you're gonna do like risk for aspiration or aspiration, you can put that. That's a nursing diagnosis, but you couldn't put like diabetes mellitus. Okay, that's a medical diagnosis. And then collaborative problems. These are problems that are managed by the physician and the nurse and some other people on the team. So the physician prescribes something and nursing implements it. So in the diagnosis step, we identify any concerns for the patient that's unique. Okay, and that's usually whatever gives rise for them to come and seek care to begin with. The diagnosis is written to describe the problem that we can treat independently. For example, a middle-aged woman with cancer failing to follow up. Although the diagnosis of cancer is important, the nurse would focus on the patient's lack to follow up, okay, and also to maybe underline the reasons why they're not following up. Maybe they lack that education. Maybe they have some sort of fear. Maybe they just are in denial. Whatever the reason is, we hopefully can get to the bottom of that problem and help the patient out. As we interpret and analyze that patient data and identify those health problems, okay, with the other healthcare physicians, we're now working collaboratively. And then we report the finding to the physician or the other healthcare, and they work with us to help resolve the problem. Sometimes we can't resolve problems on our own because it is going to take some sort of either medical treatment or further resources than what we could actually offer the patient. So again, unlike a medical diagnosis, the collaborative problems are the primary responsibility of the nurse. Unlike nursing diagnoses, collaborative problems, the prescription for treatment comes from nursing, medicine, and other disciplines. To write a diagnosis statement for a collaborative problem, not a nursing diagnosis, you would focus on the potential complication of the problem. And in front of it, it'll say potential complication or PC, followed by a colon. So then you would list the complication that might occur. All right, so it would say PC, that's potential complication, paralytic ileus related to anesthesia. All right, so this isn't your actual nursing diagnosis. This is a potential complication. Diagnostic reasoning and clinical reasoning. You have to be familiar with nursing diagnoses and other health problems. You have to read your professional literature, keep your references handy, trust your clinical experience and judgment, but ask for help, okay, if the situation arises. Give me 1 second, guys. Okay, and then we're looking at data interpretation, recognizing significant data, comparing that data to standards, looking at patterns or clusters, strengths and problems, determine any patient or family strengths, problem areas, anything that they're likely to experience, any type of complications. All right, so like if you had a patient whose blood pressure was 150/90, all right, you're going to worry about that if they don't normally have high blood pressure. Also, cluster information together, okay? Usually when we pick a nursing diagnosis, we do it because we have several factors that are pointing to that, not just one piece of data. Also, if the patient agrees with the nurse's identification of strengths and problems, then it will be easier to get them to work towards those goals and towards correcting that problem. Recognize any potential complications or detect them early. So like slurred speech, abnormal movement, changes in level of consciousness, reaching conclusions. All right, so one of 4 basic conclusions after interpreting and analyzing the patient data. So does the patient have a problem or no? If no, then we don't need a nursing response. We reinforce their habits and their patterns. We teach health promotion activities, and then a diagnosis might be indicated. If there's a possible problem, then we need to collect more data, all right, to either prove or disprove what we think. Actual or potential nursing diagnoses. Okay, we're going to start planning, implementing, evaluating care, try to reduce or resolve the problems if we're not able to treat the problem, or if the patient denies the problem and refuses treatment, then we want to make sure they understand what the possible outcomes are. And then if the clinical problem is anything other than a nursing diagnosis, then we need to reach out to our other healthcare professionals, report the change in status, work collaboratively with them, refer them if we need to, and then we're going to partner with the patient and the family in order to try to resolve the nursing issues that we did find. So make sure that the patient understands what their most important problem or issue is, and that you tell them what your assessment reveals, and talk to them about the issue so that they understand what you're doing and why. So the parts of the nursing diagnosis, we have the problem. This is going to tell us what's unhealthy about the patient. The etiology, that is the factor that caused us to have the unhealthy statement or the unhealthy state. Defining characteristics. So subjective and objective information that cue us in to the existence of the problem. So in 2002, we finally have NANDA. Okay, this is the nursing organization that is responsible for our nursing diagnosis. It is now called NANDA International. It's no longer a North American Nursing Diagnosis Association. So again, the problem describes the state of health or the problem. The etiology is causing factors or contributing factors. The defining characteristics are the subjective or objective data. So let's say my problem is aspiration. What would cause that? Maybe my patient has muscle weakness and inability to swallow. So that's my etiology. And what would be my defining characteristics? So it's evidenced by choking when trying to swallow a pill, excessive drooling. Those kind of things would be my defining characteristics. They tell me or show me about the etiology. Patient constantly coughing when they're drinking fluids. These are things I can see, right? Not just what the patient's telling me. But I can use both subjective and objective data in that. All right, problem-focused clinical judgments. This is about an undesirable human response to a health condition or life process that exists in an individual, family, group, or community. The components label, define characteristics, and relating factors. So an example would be impaired urinary elimination. Risk for nursing diagnoses are clinical judgments that the person is at risk for developing. And probably more at risk than other people. So like risk for impaired skin integrity or integrity. Health promotion, these are judgments also made about individuals, groups, or community people, okay? And they're used to try to increase well-being. So these would be things like readiness for enhanced family coping, readiness for enhanced self-esteem. And then syndrome nursing diagnosis. This is where we comprise the actual or risk nursing diagnoses that are predicted to be present because of a specific event or situation. Did somebody call me? Chronic pain, rape trauma, post-trauma. There's 4 components of the diagnosis: the label, the definition, the defining characters, and the related factors. If you look at page 373, it's going to break it down there for you more. All right, so when we're validating the nursing diagnosis, what do we want to look at? We have to validate it once it's formulated. Okay, so is the database sufficient, accurate, and supported by nursing research? Does the synthesis of my data, do the cues demonstrate the existence of the pattern? And you don't make the cues fit the pattern. All right, the cues have to fit the pattern naturally. So don't try to make them fit in because this is the diagnosis you want to have. Are they subjective or objective data that I use to determine the existence of a characteristic of the problem I define? So is there symptoms that support this diagnosis? Is my diagnosis based on scientific nursing knowledge and my clinical expertise? And is my tentative nursing diagnosis able to be prevented, reduced, or resolved by using independent nursing actions? And sometimes they might be able to be resolved completely using independent nursing actions. And sometimes you might need a combination of both. Like someone have fluid volume overload and they're a heart failure, just doing certain things for them, like restricting fluids and stuff might not be enough. I might have to actually get a diuretic or something ordered for them. Is my degree of confidence above 50% that other qualified practitioners would formulate the same nursing diagnosis as mine based on the data? Now I'm documenting, okay? So I'm looking at the patient's ongoing risk and problems and things that other people have also identified and documented. I'm deciding on the document and the new nursing diagnosis based on my patient findings. I'm communicating or promoting communication of the patient's actual health problem with nurses and other people on the team. I'm using those nursing diagnoses to make decisions about meeting mutual goals that the patient desires and what we can actually do. And then I'm determining and documenting when the diagnosis is resolved. So how's that going to help my patient? Okay, now I can direct my energy towards the priority of the patient. It's going to give me continuity of care. It allows the patient to be informed and to participate. It improves communication with other people that I'm working with. It helps define the domain of nursing to the healthcare administrator, legislators, and providers. It helps me get funding for nursing reimbursement and services. And it helps me define the curriculum, the content, and the direct specialization and advancement of nursing and research. So again, improving communication, defining the domain of nursing. This is for reimbursement and funding, and it gives us a better playing field. It makes us more equal with other sciences. Limitations. If I don't use it right, my patient could be misdiagnosed, and my nursing practice might be restricted in one way or another. So common errors, premature diagnosis based on not having enough data. Okay, so I say my patient is using defensive coping because of a comment, one comment that he made to a nurse. Okay, again, we can't base our diagnosis on one little thing. We have to have other cues and references that show us that we're headed in the right direction. Erroneous diagnoses result from inaccurate databases or from data that we get that's not true or inaccurate. A routine diagnosis resulting from the nurse's failure to tailor the data collection. So we stereotype or we put everybody in one category instead of investigating for unique and individual things about this individual person. We don't modify the diagnosis to identify new issues that the patient has when they have a status change. And that leads to failure in the nursing care itself. So we want to write the diagnosis in the term of what the patient needs and not how they respond. We want to make legally inadvisable statements. We want to make sure that we identify the problem as a problem and not what is unhealthful. We want to make sure that we identify as a problem the sign and symptoms. We want to reverse the clauses when necessary and identify a patient problem, what cannot be changed. I'm sorry, we do not want to do those things. Let me go back to that. We do not want to write diagnoses in the terms of needs, but more in the terms of responses. Sorry, that was a blonde moment. We don't want to make legally inadvisable statements. So you don't want to say things to the patient that is going to get you caught up in a court of law. Be careful what you say. When you're talking to someone about their problems, like sometimes just saying that it's not healthy is not good enough. So you want to identify it as a problem, not as an unhealthful thing. And then the signs and symptoms should also be identified as a problem, not more signs and symptoms. Don't rewrite the phrase so that it's backwards, and identify as a patient problem what the patient is not able to change. Sometimes that will lead us to error also. So identifying environmental issues rather than the patient having a problem. We want to stick towards the patient. Both clauses should not say the same thing in your nursing diagnosis. Each thing is going to be something separate. Don't include your value or your judgment in the diagnosis. And don't use medical diagnosis in the diagnostic statement, which we already talked about. All right, a nurse decides that the patient has a possible problem with high blood pressure. During which step of the interpretation is this most likely be determined? So it would be in the conclusion part, right? Because we would have to compare, go back and look at what their baseline is. All right, because everybody can be a little different with this. It might be high for one person, not necessarily high for another. If they have a history of high blood pressure, I have to look at what the blood pressure is and what their baseline is. Data cluster, this is grouping patient data or cues that points to the existence of the problem. And then identify strengths and problems and determine if the patient is motivated to address them. A patient who admits smoking 2 packs of cigarettes a day is diagnosed with lung cancer based on his symptoms and a scenario of test results. Which of the following is the etiology in the scenario? So the etiology is what?
C.
See,
It means what though?
It means that the problem came from smoking cigarettes.
Okay, good. It's the cause, right?
Yes.
Which of the following nursing diagnoses is written correctly?
Well, I think we already seen that the right answer is it D? We seen it
Okay.
before we showed it.
Okay, that's okay.
Okay.
We're learning here, so it doesn't matter if you don't know the right answer. Hopefully you learn it today. All right, so it's D, imbalanced nutrition related to insufficient funds in the meal budget. Okay, A is legally inadvisable statements. Okay, child abuse related to maternal hostility. It's really kind of making an assumption there. Breast cancer is a medical diagnosis, so you can't use that. And C reverses the clauses. So it's alteration in diet related to knowledge deficit. So that's what it means when you reverse it.
Okay.
Their problem is they're not eating enough, or they have an alteration. And the reason why they have that alteration is because maybe they don't know what they should be eating, or they're not following the proper guidelines.
Makes sense.
Following statement, true or false? A nursing diagnosis may be used to seek reimbursement for nursing services.
True.
Yeah, true. So following statement, true or false? The nursing diagnosis, risk for impaired skin integrity, is an example of a correctly written diagnosis, risk diagnosis.
False.
So that's true.
Oh, I thought it was incomplete. I'm sorry.
So with risk 4, you don't always have the full criteria that you have when you have an actual nursing diagnosis.
Okay.
So, Miss Sue, for the risk 4, then you wouldn't need like risk 4 skin integrity related to incontinence.
Well, you couldn't, I guess you could use incontinence if it's not considered a medical diagnosis. You would use more like loss of bladder or moisture next to the skin, those kind of things. Because you can't use, remember, you can't use medical diagnosis. And I think incontinence might be considered a medical diagnosis.
Okay.
Oh, okay. It says risk diagnosis. Okay, that makes sense.
Let me just see if I can find something else to break it down for you a little bit better.
Yeah, because on a test, I would have not picked that because I would have thought it was incomplete if it didn't say related to.
Right. That's what I was gonna say, the same thing. It didn't have the related to.
But when I reread the question, it says the nursing diagnosis semicolon, but in the end it says risk diagnosis. So that made it more specific. So now I could understand why that is correct. But if the question was worded different, I think we should look for the at risk for or related to. Am I correct, Ms. Loesch?
So the second type of nursing diagnosis is a risk nursing diagnosis. This is a clinical judgment that a problem does not exist, but the presence of risk factors indicate that the problem is likely to develop unless the nurse intervenes. There are no etiological or related to factors. The individual or group is more susceptible to develop the problem So you might say risk for falls as evidenced by muscle weakness, but you wouldn't have that related to factor in there.
Okay.
So let's say my diagnosis was risk for ineffective breathing and it was related to poor tissue perfusion or something like that. I wouldn't be able to put that if that related to factor in. Now, if I were putting the actual, what did I just say?
As evidenced by?
No, the one that I said is the diagnosis, ineffective breathing.
Oh,
If I
ineffective
said risk
perfusion.
for ineffective, I wouldn't be able to put the related to part in it. I would just be able to put risk for ineffective breathing as evidence by, and then whatever my evidence is.
Okay, because it has not happened yet.
Because there is no etiology for it at the moment. It's just a risk.
Okay.
I don't know what would cause
Okay.
the etiology. It could be a number of things.
Okay.
But if I said ineffective breathing pattern related to inflamed airway as evidenced by shortness of breath, increased respirations. You see, now I have an actual nursing diagnosis. My patient actually does have this ineffective breathing pattern. And it is related to the fact that their airway is inflamed. There's excessive productive mucus being formed, right? Those things are impairing that airway. And then I can put as evidenced by also on there. So it would be ineffective airway related to whatever that causative factor is. And then as evidenced by, so what things show me that the person has ineffective breathing or ineffective airway? What kind of things are showing me that? They're either going to be cyanotic, okay? They're going to have an increased work of breathing. Something's going to be going on there, then I'm going to see that that's happening. But if they're at risk for fall, they haven't actually fallen yet. So there's no actual cause there at the moment.
Okay.
But we have evidence that supports that they're at risk. So we're just going to use that evidence as our supporting factor. Does that make more sense?
Yes.
Okay, we're going to see if we can get through chapter 16. I'm going to have to probably stop about 1/4 of. I'm going to get as much in here as I can before then.
Thank you.
Okay, so outcome planning and identification. We have to first establish our priorities. Then we would identify and write the expected patient outcome. We would select evidence-based nursing interventions and communicate that care plan. So for outcome identification, we have to think about things like the law. Okay, what are we allowed to
Miss
practice?
Susan,
Not sharing it, right?
yes.
Right.
How about now?
Yes.
All right. So we're looking at national practice standards. What kind of organizations help support this? The Joint Commission, they set a lot of guidelines. The Agency for Healthcare Research and Quality and your employer. They're all going to have something to say about this because they're going to have policies that surround this. What we need to do is we have to individualize or make that care unique so that we can get the best outcome for our patient. And the idea is to get this continuity of care and help the patient achieve their maximum outcome so that we can get rid of these either potential problems or risk for problems. So we're going to set priorities for the patient. will communicate among other nursing personnel and our colleagues to try to promote this plan of care and make sure that everybody's on the same page. This is going to help provide a continuity of high quality and cost-effective care. It will help us coordinate that patient care. It'll help us evaluate the patient's response to the care because everybody's on the same page. We're all following the same regimen. We're creating a record. We can use that record for evaluation, research, reimbursement, and any other legal reasons we might need it for. And it helps promote you as a nurse towards professional development. We have to be familiar with the standards and any agency policies that are in place for setting priorities, for identifying and recording the patient outcome, and for selecting our evidence-based nursing interventions and recording the care plan. The goal of the patient-centered care is to keep the patient and the patient's preferences in every aspect of planning. So when you're doing outcome identification, you're looking at goals that you want this patient to meet. And if your patient doesn't agree on the goals, or they're not on the same page or in alignment with you, that's going to be an issue. So we have to have the big picture in focus. What would be our discharge goal for the patients, and how would we direct the interventions towards meeting those goals? Again, when you're doing your care plan and you're doing all this, everything needs to be married together. All right, everything headed in the same direction. So what exactly do I mean by that? I'm setting this goal for my patient. Maybe my patient is at risk for aspiration. I know I'm talking about that one a lot today. But they're in the hospital. They recently had a stroke, okay? And we're worried that they might aspirate because we came in and we gave them some water, and we noticed that when they were drinking the water that they were doing a lot of coughing. All right, I'm not going to keep giving them water because if someone's coughing when they're drinking, they're aspirating. If I keep giving them water, I'm going to contribute to them getting that aspiration pneumonia. So I need to have somebody come in and do a swallow eval. So I need to reach out to my physician and say, listen, this patient appears to be aspirating. Can we order a swallow eval? And this physician's probably going to say, yeah, sure, thanks. They don't want their patient to aspirate. And then they're probably going to put the patient on an MPO status. Okay. And then in the interim, you're going to set this up for them to be evaluated. Now, let's say in the meantime, you need your patient to be MPO, right? You need to tell your patient that, because what's happening between the time you leave that patient's room and you come back 2 hours later?
Breakfast, lunch, or dinner.
Or family.
Or family.
Which is the biggest culprit. Okay? Because here I am lying in the hospital, and what am I saying to my family?
Bring me some food. Bring me a tea.
They don't feed me.
I'm hungry. This food nasty in here.
We so sold and they don't.
Okay, so family comes in with the big Slurpee or whatever, and they give it to the patient. So, you know, your patient has to be, an outcome of your goal here for your patient would be to prevent the aspiration. So you would have to teach your patient, and a goal for them would be to be able to verbalize an understanding that they have to remain MPO until they get that swallow study. Because if you don't tell them that, they're subject to drink, okay? And other people are subject to give them drinks. You're gonna have to tell the family too, because even though you tell them that, if they're thirsty, guess what? They're probably still going to drink. Oh, it was just ice chips, nurse, because you can't aspirate on them, right? Right?
You can.
Okay, thank you. So, you know, you want them to understand this, and if they understand it and they buy into it, then they're more likely to do it. Now, it's not just important for you to set this nursing diagnosis, put this goal in place, make sure your patient's following it, but now you have a care plan in place, and hopefully the other nurses coming behind you are going to follow it. So this way we have some kind of continuity. Everybody's doing the same thing to prevent this patient from aspirating. And believe me, everybody has to be on board on that page, or your patient is going to aspirate because somebody is going to walk in that room and give them something they're not supposed to have. So when you're doing this, you want to trust your clinical experience and judgment. Ask for help if you need it. Allow others to collaborate and be part of the team. Respect what your clinical institution's priorities and decisions are, and make sure that whatever you do represents what the institution policies are. And make sure that you're aware of your own personal biases and you keep an open mind. 3 elements, okay, of comprehensive planning: the initial planning, the ongoing planning, and the discharge planning. Which nursing action would most likely occur in the ongoing planning stage?
It's either A or D.
A.
A.
Okay, good, A. Okay, the nurse collects the new data. She uses it to update the plan and she resolves the health problem. In the ongoing planning stage, any nurse that interacts with the patient will update the plan to facilitate the resolution of health problems, manage the risk factors, promote the function. Teaching and counseling are key to discharge planning. The nurse is performing admission, nursing history, consults the standardized care plan and the initial planning to formulate the initial care plan. Just looking up one thing real quick in your book. So if you go to page 389 in your book, as I can find it. All right, the initial planning is going to be performed by the nurse with the admission, nursing history, and the physical assessment. The comprehensive plan addresses each problem listed in the prioritized nursing diagnosis and identifies the appropriate goals in the nursing care plan. A lot of hospitals and stuff use standardized care plans now. So that's why you really have to look and listen at what they have to say. Ongoing planning, that's any nurse that interacts with the patient. And the idea is to keep the plan up to date, to resolve the health problems, manage any risk factors, and promote function. And you'll add new data as it occurs and update the plan or make it more specific as you go along. And then discharge planning is best carried out by the nurse that has worked most closely with the patient and the family. And you're going to use your knowledge, okay, of community resources to help this patient to plan for once he's out of the hospital to continue to carry out this care plan at home with his own self-care and his own behavior. So when we derive patient goals or outcomes, we get them from nursing diagnoses. So the first part of the nursing diagnosis is going to be the problem statement. That identifies the unhealthy response and indicates what should change. The second part is the etiology, and that identifies factors causing or contributing to the undesirable response and preventing that desired change. So again, the initial planning is going to be developed by the nurse that performs the history and physical assessment. We identify the problems listed in the prioritized nursing diagnosis. We identify the appropriate patient goals related to nursing care. The ongoing planning that's carried out by all nurses that interact with the patient. We're keeping the plan up to date. We're managing risk factors, promoting functions, adding new data as it becomes available. We're identifying nursing interventions that will help us accomplish those patient goals. And remember, it has to be specific, clear, and we have to be able to measure it. So if my patient is supposed to understand that he's to remain NPO until the swallowing study is done, then I have to make sure of a few things. One, that the call bell is at his side. Two, that he understands that he can't have anything to eat or drink, okay, until that time frame. And so I would write it. Patient will verbalize an understanding of remaining NPO within 2 hours of admission, okay? We'll verbalize an understanding of remaining NPO until after the swallowing study within 2 hours of admission. Now I have a time frame. I have something I can go back and look at. Did my patient actually meet this goal? If I were doing something like their oxygenation, okay, I'm not going to say my patient will maintain a pulse ox within normal limits, because that's not measurable. And I don't know what normal limits is for the patient if I'm coming in off the floor. If my patient's COPD, their normal O2 sat might be 88. Somebody else might be 92 and somebody else might be 100. So what I need to do is write it so that it's specific. Patient will maintain a pulse ox of 92% or greater for the next 4 hours. Now I have a specific and measurable outcome or goal. And then discharge planning carried by the nurse that works closest begins with when the patient is admitted, uses teaching and counseling skills, okay, and outside resources. So we prioritize by which has the greatest threat, okay? Again, look at Maslow's. So if I have ineffective airway versus a circulation problem, I'm going with the airway first. So high priority, greatest threat to patient well-being, medium priority, non-threatening, and low priority, a diagnosis that they might have, but it may not be specifically related to what is currently happening with them in the hospital. Which nursing diagnosis would be most likely considered a high priority?
B.
B.
B, yes, gas exchange, right? That's a physiological component. It's life-threatening. It falls under Maslow's first level. So for Maslow, we're looking at the chain, okay? 1 is physiological needs, 2 is safety, 3 is love and belonging, 4 is self-esteem, 5 is self-actualization. Self-actualization is the mode you're in right now. You're trying to achieve a higher level of education, a higher level of self-respect, a higher level of who I am. You're growing towards being more professional. Self-esteem, this is when, you know, our image, our body image and stuff is affected. Love and belonging, you know, our family needs. We need to feel part of a family. And safety, we're worried about falls. Okay, physiological, air, water, nutrition. So what problems need immediate attention? What do I need to fix right now? What can wait? What is your problem and what should you be referring out to someone else? What problems can be dealt with by using a standard plan? So let's say you have a standardized care plan in your facility. Does it fit your patient's needs? Don't make your patient's needs fit the care plan. Make the care plan fit your patient's needs. Which problems are not covered by protocols or standards? Have any changes occurred in the patient's health status that influenced what we currently wrote or what we have in place? Have any changes in the patient's response to the health or illness occurred? Is there any relationship between the diagnosis that we previously had and another one that can be worked on so that we can resolve them? And is there any list of patient problems that could be worked on together. So maybe the patient has 4 or 5 problems, but maybe I can address all those problems in one care plan. Now, I don't want my care plan to be overwhelming. So you're not just going to smudge stuff in there. It has to be correlated. It has to fit. We don't make it fit. Long-term outcomes require a longer period. So usually we use these as discharge goals. So when you're thinking about your long-term goal on your care plan, okay, if my patient has a hip fracture and I'm releasing them from the hospital, a long-term care goal might be to follow up with physical therapy once they get home, because they're still going to need those physical therapy appointments. So let me help them with that long-term plan. Short-term is usually going to be just that. It can be done in a couple of hours. It might be 48 hours. But usually this is done before the patient is discharged. There's really no rules on this, okay? But when we think about long-term, we think about the long haul. Aims to be met, okay, for quality of care. So we are expected to be safe. We should not be what caused our patient's injury. We have to avoid over and underusing certain things. So we got to be effective. Our care has to be patient-centered. It has to meet the needs of the patient. The time, okay? We don't want delays in treatment. And we have to be efficient, meaning we don't waste stuff. So how does that work? Well, if my patient has a wound, okay, and I know that my policy of my facility is if I use normal saline on something, I have to throw it out in 48 hours. I'm not going to open a 200 ml bottle of normal saline, use 10 or 15 cc's out of it, and now if I don't use it again by tomorrow, I got to throw the whole thing out. I should open really a 5 cc bottle of normal saline or a 50 cc bottle of normal saline so that I'm wasting as least amount as possible. Equitable, providing care that does not vary in quality to all recipients. Okay, so in other words, everybody should receive the same amount or the same kind of treatment. Oh, you're Medicaid? Oh, let me go get the other stuff and use it on you because you don't have insurance. So I got this other product. It don't really work that great, but it's okay because you're not paying for it anyway. And I'll give the good stuff to the people that have the good insurance. That's just like putting a liquor store on every corner in certain neighborhoods and not putting a clinic there, but in other neighborhoods, you have a hospital, a clinic, doctor's offices. I can actually walk there. I can get there. You're not giving me equitable care. And this is why there's a huge push to eliminate the disparities in healthcare. All right, cognitive, this is what a patient knows, what they can learn, what they understand. Psychomotor is movement. So if I'm walking someone to the bathroom, I'm engaging them in psychomotor skills. If I'm teaching them how to wash their hands, I'm engaging them in cognitive skills. If they're actually washing the hands, then it could be psychomotor. Affective. This is changes in their value, their belief, or their attitude. If they don't value what I'm doing or it's not part of their culture, then they may not do it or they may not engage because they're not going to believe in it. Which outcome is an effective outcome? So remember, we're talking about values, attitudes.
D.
Okay, I like D.
D.
D is in dog. An effective outcome describes changes in the patient's value, belief, and attitude. All right, clinical outcomes describe the expected health status that we expect to see. They address if the problem is resolved and to what degree they have improved. A functional outcome is the way the person is able to function. So like, are they able to button their shirt on their own? Are they able to perform their ADLs? Quality of life focuses on things that affect somebody's ability to enjoy life and achieve personal goals. Expressing the patient outcome as a nursing intervention is a common issue, okay? Our interventions are things we're going to do to achieve that outcome. Using verbs that are not observable or measurable, including more than one patient behavior or manifestation in the short-term outcome, and writing vague outcomes. So again, they have to be clear, specific, and measurable. So they'll have a subject, they'll have a verb, they'll have conditions, they'll have a criteria, and they'll have a time in which we expect to do it. Is the following statement true or false? A collaborative intervention is an intervention initiated by a physician in response to a medical diagnosis, but carried out by a nurse in response to the order. This is a little tricky, okay? That's false. A physician-initiated intervention is an intervention initiated by a physician in response to a medical diagnosis, but carried out by a nurse in response to a physician's order. So let's go back and read that again. The collaborative intervention is what it asked us about, okay? But the answer was false because it's a physician-initiated intervention that is initiated by the physician. All right, a collaborative one actually could be also initiated by the nurse, right? The nurse could come in, see the patient, decide that the patient needs something that she can't provide at her scope of practice. So she reaches out to the physician and the team, who then gives the orders and she can carry it out. But it could be initiated by any team member. All right, nurse initiated actions performed by a nurse without the order. Physician initiated is actions initiated by the physician in response to the diagnosis, but carried out by the nurse. And then collaborative is treatments initiated by other providers and carried out by the nurse. Monitor the health status, reduce the risk, resolve, prevent, or manage a problem, facilitate independence or assist with ADLs, promote optimum sense of physical, psychological, and spiritual well-being. All things that we expect to happen when we initiate a nursing intervention. So we maybe initiate monitor vital signs, or we're monitoring for some change in the status. Okay, we're doing things to reduce the risk. We're doing things to help resolve, prevent, or manage a problem. We're doing things that will help that patient with independence, ADLs, and optimum sense of well-being. We're setting procedures, okay? Structured care methodologies. We have a procedure of how to do it. We have a standard of care, an acceptable level of patient care. We use these algorithms, okay? They give us a set of defined steps to make a decision. So if this happens, if this happens, we would do this. But if it goes the other way, then we would do something different. You'll see these a lot of times with things like CPR, cardiac interventions. You even see it with the APGAR scores with babies. Like if the baby's not doing this, you want to do this. Clinical practice guidelines. These are statements that outline the appropriate practice for that setting or condition. Is the following statement true or false? A protocol describes specific therapeutic interventions for a clinical problem unique to a subgroup of patients within the cohort. A protocol prescribes a specific therapeutic intervention for a clinical problem unique to a subgroup of patients within the cohort.
True.
Yeah, that's true. Where do you see protocols at?
And policy and procedures.
Yeah, but a lot of times you'll see them in places like the jail, right? Why?
To make sure everybody's following what they need to follow.
Yeah, sort of.
To make sure it's done the same way each time.
Yeah, consistency and continuity, and these doctors put these orders in place because this jail doctor don't want no calls at 2 o'clock in the morning for someone who needs Tylenol. Right? So they put these protocols in place to give the nurse a specific guideline that they can go by when the doctor's not there, without going above and beyond their scope of practice. So we put these protocols in place, and then it's for a specific group of patients in that cohort. So all the people in this cohort could be on this Tylenol protocol or this temperature protocol or this head injury precaution protocol that we're going to follow. And it gives us specific steps to follow when we complete that intervention. Institutional care plans, we have a few. We have computerized ones. They're usually some sort of standardized care plan for each person. And then we can titrate them to be more unique if we need to. Concept maps are kind of along that same guideline. They give us specific steps to follow. Change of shift reports, multidisciplinary or collaborative plans of care, and student plans of care. We use the NIC or the NOC standardized language. This helps to demonstrate the impact that we as nurses have on the system. It defines the knowledge that we use in the nursing curriculum. It facilitates the appropriate nursing intervention. It helps promote communication of nursing treatments to other nurses and providers. And it allows researchers to examine the effectiveness and cost of nursing care. And then the benefits is that it allows us to develop better curricula that really goes along with that clinical practice and brings the whole thing into that holistic care. It helps us teach the clinical decision-making to new nurses that may not have worked out on the floor yet and maybe don't know. It helps us to plan more effectively for staff and equipment needs. It promotes the development and the use of nursing information in the system. And it also helps us communicate the nature of nursing to the public in general. Questions? All right, if you need the lectures that are on YouTube, send me an email. I'm going to try to send the lectures that I already have recorded out to all of your group by this evening. Okay, for those of you that are in days. So the more people that send me emails, the easier it'll be for me to access. And then the ones that are recorded, I'll try to get them out to you tomorrow.
Thank you.
All right, guys, have a good day.
Thanks.
You too.
You too.